Welcome, future doctors of India, to Sri Chhatrapati Academy Study Ayush Forum by the students for the student. Okay, so today we will start our new topic. Welcome to the field of treatment. So, our today's topic, the interesting topic is pleura, anatomy of pleura. What is pleura? Whenever you read about it, question comes in our mind: what is a pleura, or what is a peritoneum, or what is a mesentery? What all these rubbish things are coming? We have to learn organs and why these rubbish things, pleura, peritoneum, mesentery, all are coming. So these are the protective functions or protective structures which covers the vital organs. Peritoneum covers the abdominal cavity. Mesentery covers the small intestine. Your pleura covers the thoracic or your lungs. So these are very essential concept or essential structure which protects your lungs. Now, pleura, it is present on the both side. Yes, it is present on the both side, right and left. We have two lungs present in our body, right lung and left lung. But there is a structural difference. What are that structural difference? We will study today. What it is blood supply, what is nerve supply, what is a pulmonary ligament, what is a recess. All this we will do in this today's lecture. Now let us start. Pleura. What are its characteristic feature? What is nature? It is like a peritoneum, and it is made up of a serous membrane. Now what is a peritoneum? Peritoneum is a covering of a abdominal cavity which protects the organ in the abdominal cavity. Peritoneum, pleura is same for that of lungs, which is made up of serous membrane which contains the serous fluid which reduces the friction whenever lungs contract or lungs expands during the inspiration or expiration process. It is made up of a mesothelium, cells of a mesothelium, which is nothing but a flatel epithelial connective tissue. There are two sacs present on either side of the mediastinum. What is a mediastinum? Mediastinum is a space where our heart is present, which is tilted towards the right side. Evagination. Each pleural sac is evaginated from the medial side by the lung. So it has two layers, which is called as parietal and visceral pleura. Now let us understand this concept by drawing a lung. Let us assume that this is a lung, and here there is a root of a lung, or there is a hilum of a lung from where the blood vessels are coming out. That pleura is evaginated. This is a medial side. It is evaginated from the medial side by this root of lung, and it again goes back. So this forms the two layer, which is called as, this is called as parietal layer, which is outer layer, and which is called as visceral layer, which is inner layer. Visceral layer is also called as pulmonary layer because it is a contact with lung. Okay. The parietal and visceral pleura are continuous with each other around the hilum of the lung. You can see here clearly it is continuous with each other in the root or the hilum of the lung. Now the pleural cavity. So as this parietal and visceral pleura are forming, there is a space between. This is called as pleural cavity, which is called as pleural. This was all about the characteristic feature of the pleura. Now we will see detail about the pulmonary or the visceral pleura or the internal pleura. Okay, it is a serous layer of a pulmonary pleura. Okay, it covers the surface and the fissure of the lung. It is in close contact with the lung. Very easy to understand. It does not cover the hilum and along the attachment of the pulmonary ligament. very easy, very important to understand, that it does not cover the hilum. Visceral pleura does not cover the hilum and the attachment of the pulmonary ligament. Pulmonary ligament is nothing but the extension of this pleura around the hilum of the lung. As these sites is continuous with the parietal pleura, and here this visceral pleura is continuous with the parietal pleura. We have seen in the previous slide that at the hilum of the lung, the visceral and parietal pleura are continuous with each other. It is firmly adhered to the lung and cannot be separated from the it. This visceral pleura is firmly adherent towards the lung. It is closely attached to the lung, and whenever you dissect, you can't remove that pulmonary or visceral pleura. See, this is the parietal pleura, this is the visceral pleura, and the space between it is nothing but your pleural cavity. Okay, see, you can understand here, this is a parietal pleura. It is an analogy which is compared with a balloon and the hand. This is your lung, this is your root of the lung, and here it is a parietal pleura, and it at the root of the lung it goes again backwards and form the visceral pleura. See, very nice analogy I have brought here for you. Now let us understand the parietal pleura, what it is. The parietal pleura is thicker, okay, than the pulmonary or the visceral pleura, and it is subdivided into the four parts: costal, diaphragmatic, mediastinal, and cervical pleura. Now this is the costal, which lines the inner surface of the rib cage. Costal pleura, whenever you see the anterior side of the lung, whatever you come to understand, there is a presence of a rib, there is a presence of a rib and the intercostal spaces between that ribs. So this parietal pleura is attached to the attached to the ribs or the thoracic wall with the help of a areolar loose connective tissue called as endothoracic fascia. Mark it, it is a MCQ question, that the costal pleura and the ribs or the thoracic wall is connected with each other with the help of a areolar connective tissue called as endothoracic fascia, right? Diaphragmatic, it is a base, which it is a base and is a superficial surface which connects the diaphragm and the lungs. So it is a diaphragmatic pleura. All are connected with each other. There is a nothing. It is a whole. But as the compartments are given, or as the at which it faces, or in which organ it comes, or in which section it comes, the names are given as per its convenience, which is easy to understand. Mediastinal. Mediastinal lines the mediastinum of the left side of the. It is tilted towards the left side. So it is also a third type of pleura called as mediastinal parietal pleura, and a cervical which comes at the apex. This is the apex. Here it comes extends above the first rib to the root of the neck. First rib extends 5 cm from the first rib and 2.5 cm from the 1/3 of the median surface of the clavicle. There is the apex of the parietal cervical pleura. Now let us see the surface marking. Surface marking is essential in regarding to the lungs or in regarding to the pleura. Now where you see here the first point. At the first point it is called as apex. This pink color line shows the visceral pleura, and this blue color line shows the parietal pleura. First point here is the apex. This apex lie 5 cm from the first rib and 2.5 centimeter from the median 1/3 of the clavicle. Second point lies at a sternoclavicular joint. Okay. Third point lies near the sternal angle at a level of second costal cartilage. Fourth point lies at the fourth costal cartilage. Sorry, here is not a fourth point, here is a fourth point which lies as the third costal cartilage and it curves down. Same till the fourth point, it is same at the left side, but from the fourth costal cartilage it takes the turn 3.5 centimeter and comes at the sixth point, and here it forms the space called as cardiac notch, where it is a mediastinal space where your heart is present. It is called as cardiac notch, and here there is a very here there is only the parietal there is a only pleura which covers the pericardium, so it is very less to hear the percussion site on this surface, and hence it is called as area of superficial cardiac dullness, where you can't hear the noise, you can't do the percussion over this surface. Very easy. Now when you see the parietal pleura, it also follows the same path as that of your visceral pleura, but it is little bigger than the visceral pleura. So here there is a formation of a space, formation of a cavity for accommodation of the inspiration and expiration expansion of the lung. It also follows the same point. Apex is here. It follows downwards, 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 and towards the sixth point it follows the mid clavicular line, mid axillary line, and then at the 12th costal cartilage it follows a 12th costal cartilage goes back and follows the parietal pleura. What I want to say, this is a two-dimensional structure. Imagine it is a three-dimensional way, and whenever you want to understand there is a mnemonic or there is a that even number shows the root of the lung. Here they start the shows the surface marking of the lung. Here at the second costal cartilage they start together like this. At the fourth costal cartilage they diverge. Okay. At the sixth costal cartilage they separate and goes. At 8 they are present on the mid axillary line. At the 10th they are present mid clavicular line, mid axillary line. At 10th they are present on mid axillary line, and at the 12th they goes backwards. This is all extra information, but the surface marking keep one point which is very important, that from the fourth point or the fourth costal cartilage the left lung, the left parietal or parietal visceral pleura goes 3.5 centimeter inwards and then descend towards the sixth mark, and here the space is formed, is called as cardiac notch, which is very important. Pulmonary ligament, the one of the interesting feature, the parietal pleura surrounding the root of the lung extends downwards beyond the root. The parietal pleura, this is a parietal pleura, here is the root of the lung, here is a parietal pleura, and here is the root of the lung, and it extends downwards, and here the all the openings are there, your veins and all. This extension downwards, it forms the fold which is called as pulmonary ligament. This is nothing but your pulmonary ligament. The fold contains a thin layer of a loose areolar tissue with few lymphatics. Lymphatics are present over here. It provides a dead space into which the pulmonary veins can expand during increased venous return. Whenever there is a increased venous return, it is helpful. So it is an adaptive function. Adaptive. The lung roots can also descend into it when the descent of a diaphragm. Whenever there is a descent of a diaphragm, the the roots of the lung also descends in it. So it is an adaptive or a very protective function. Whenever there is a need, it can be used. Now, recesses of a pleura. Now, what are the recesses? There are two recesses of parietal pleura which act as a reserve space for the lung to expand during the inspiration. Recess means a space provided. So, there are two types: costo-mediastinal recess. See here, you can see costo-mediastinal recess, and the costo-diaphragmatic recess. See the diaphragm and is a costal region, so here is a space. Lies anteriorly behind the sternum and costal cartilages, lies inferiorly between the costal and diaphragmatic pleura. You can see here. Its importance is during inspiration, the lungs expands into this recess. Wherever there is an inspiration, the lungs expand, and here a space is provided for the expansion of the lungs. Clinical note, very important, and it is an extra topic. These recesses are obvious only in expiration and not in deep inspiration. Whenever you are doing the deep inspiration, they are not useful. They are only useful in expiration. Pleura, development and nerve supply. Parietal pleura develops from somatopleuric layer, and it develops from spalcanopleuric layer of a lateral plate mesoderm. What is that? We will learn detail when we study the embryology. Supplied by somatic nerves, supplied by autonomic nerves. Difference see. It is not sensitive to pain, but it is sensitive to pain because it is somatic nerve which we can feel, and it is an autonomic nerve, so it is not a pain sensitive. Sympathetic system dilates the bronchi in the lungs. That are we will study more detail whenever we study about the lungs. Parasympathetic narrow the bronchial tree and also secrete to the glands. It is a physiological function. Now the blood supply. Blood supply of parietal pleura. Blood supply supplied by intercostal, internal thoracic and musculophlenic arteries and drains from azygous and internal thoracic veins. Same lymphatic drains into intercostal, internal mammary, posterior, mediastinal and diaphragmatic nodes. They are the nodes. It is very important to learn it. It is all rectification process, nothing to explain because it is an anatomical structures. Now the blood supply of the pulmonary pleura, it's supplied by bronchial arteries because it is visceral pleura, okay. Venous drainage drains into the bronchial veins, and lymphatic drained by bronchopulmonary lymph nodes which is present in the thoracic region. Clinical aspects of pleura: parasynthesis thoracis. This is a process in which aspiration is done from the lungs, in which the needle is given to the 8th thoracic rib or cartilage, and from that the fluid is removed, and that fluid is tested 8 intercostal space, sorry, not the rib, it is removed from the 8 intercostal space in the mid axillary line. The needle is passed to the lower part of the space to avoid injury to the principal neurovascular bundle. Okay. Now the second condition associated with the pleura is pleurisy, which is an inflammation of pleura or the fluid present in the pleura. Now the pneumothorax means the air, excess air present in the pleural cavity. Pneumothorax, presence of excess air in a presence of excess blood in a pleural cavity. Hydrothorax is also present where the fluid is present. Hydropneumothorax is the presence of both fluid and air in a pleural cavity. Empyema, presence of pus in a pleural cavity. Shoulder pain. Pain on right shoulder occurs due to the inflammation of gallbladder, while left shoulder is due to the splenic rupture. Referred pain, coastal and peripheral parts of diaphragmatic pleura are innervated by intercostal nerves. Hence, irritation of this region causes referred pain, and intercostal nerves to thoracic or abdominal wall. See, this is also important condition. Pleural effusion causes obliteration of crostodiaphragmatic recess. Obliteration means closure of that recess. So you can imagine, if there is a closure, then how the deep expiration, how we can get the space. So there is a formation, there is a disease. So it is also one of the clinical part. See, you can see here, this is a paracentesis and there is a fluid accumulation over here. You can see in the diagram. Okay. So for today, it's over. We have completed our pleura. It is very important. In the next, we will in the next or next lecture, we will complete our lungs. So till that, keep studying, ask doubts, and do the clinical practices. Thank you.